about 6-year-old female presented. Initially, she had emphysema and a PE, and then she was found to have an acute left lower extremity DVT with phlegmatosis changes. This is her CTV from the ED. Come through, a lot of images here, but as you come down, you can see that there's slight compression of the left common iliac vein, and then you've got central thrombus. You've got acute thrombus going all the way down. I'm not going to belabor the point, but it goes down, through most of her thigh. So case number one for her, we went from a popliteal approach, did a pretty standard clot tree thrombectomy. So you can see here, we have our wire up. We did some educational contrast injections. Sometimes I just rely on IVUS for this or the ultrasound from before. Did a nice clean thrombectomy with the clot retriever. She did end up having residual stenosis with collaterals that required a stent in the left common to external iliac vein. Great flow at the end of the case. 6-week follow-up. She was supposed to follow up in 4 weeks. She did not. 6 weeks follow-up, she's claiming that she had missed a few doses of her Eliquis. Her daughter, who's a nurse, gets it out of her that she basically did not take her Eliquis. So as you can imagine, the CTV that I get as a follow-up for my any stent placement shows that her stent is, nearly occluded. There's, a hint of a channel there throughout the stent. So she has an in-stent thrombosis from medication non-compliance. I think it was a medication issue, medical education issue. So this is our venogram. Surprisingly, the thigh, the popliteal through femoral and common femoral are open, and then you get a wisp of contrast going through that iliac stent. So this, I decided to go from a popliteal approach. So the patient was actually prone, and I did a bilateral popliteal approach. You'll see why in a second. For crossing these chronic occlusions, luckily, she was kind of in the subacute approaching chronic phase because we don't really know when that stent went down. One of the things that I like to use is a Roadrunner wire, because you can curl it over on itself, and I use predominantly Abre stents. So they got these large interstices and spaces there that the wire can, transgress and go through and then back in, and et cetera. So one of the ways that I get around that is by actually having the Roadrunner floppy fold over on itself and push it up as a bent wire all the way through. I've also used a reverse curve catheter in some other instances, like a SOS, where you can actually push it through the channel. And then confirm with both IVUS and in really hairy cases, I'll confirm it with cone beam CT. You can see that we got lucky that there was a channel here and that the wire ended up going through fairly easily. We did end up going through one of the interstices there into the IVC, but we repositioned and we ended up with the wire position here, where it's actually not through one of the interstices, even though it looks like it. We did put up the FlowTriever 1 catheter with the 3 discs from the right side, and we then did our first safety pass of RevCore, and then dialed it up to 0.5 with intermittent aspirations with the Triever catheter, and slowly dialed it up. And you can see this is kind of the junk that we're getting off, and it was well maintained and trapped in the RevCore device. There's a lot more than this. This just happened to be the one picture that we did capture during the case. So with the aggressive scrubbing, one other thing that I found is helpful is, because this kind of, there's a really good description Dr. Bromwood said, is that it's kind of like a lathe, and it's not really scooping huge pieces off at once. It's kind of shaving it gradually down. And one thing that I've found to decrease my procedural time is doing intermittent angioplasty and increasing the angioplasty size. So angioplasty to 12, I hit it with the RevCore again. You can see that I got a little bit more of a channel there. And then I did the same thing where I angioplasty to 14, then hit it with the RevCore. And this was a 16 stent. So I finally did my final set of images on the right, where I took it to a 16 and then hit it with RevCore again. You can see we get a nice result with a nice clean lumen, and then a little bit of a pseudostenosis due to the increased flow in the external iliac and common femoral. And since the flow was so good, we did not extend the stent. The IVUS pictures kind of corroborated that we had really great flow through there, and that was just increased flow resulting in decreased venous pressure, and then the vein was collapsing itself.